I know you all had wanted learning outcomes. So these are basically the objectives for thorax week. Okay. Mediastinum week objectives you will get later, the following, I think 2 weeks later. Now, what should you know? At the end of this week, you should be able to identify the bony landmarks on the chest and surface mark the important structures of the thorax. This first objective is all important. This is what you are going to carry to your clinicals, to your professorials, and for the rest of your life. So please know how to identify the bony landmarks. Surface anatomy is always extremely important. Identify the thoracic apertures and their relations. I will tell you what a thoracic aperture is. These are new nomenclature or new wording that we are using in the place of what we learned when we were students, because they make a bit more sense. List the bones that make up the bony thorax and describe the bones, very important in vivas. Describe the movements of the thorax and relate how these movements apply to changes in dimension. All of these ones in blue are your bone objectives. Then the red ones, we go to muscle. Describe the muscle layers that make up the wall. Describe an intercostal space. Now these, mind you, are all either MCQ, structured essays, or vivas. Okay, so pay particular attention. Thorax is a very small area, not like the huge upper limb, lower limb areas you all have been doing all this time. It's actually very easy, but you have to pay attention to some little detail, right? Then identify arterial supply, venous drainage, nerve supply. Describe the surface anatomy of the pleura. This has been given very often as a long question, essay question. Discuss how it differs from the surface anatomy of the lungs. So purple is pleura. Then green, we go into the lung proper. Briefly describe anatomy of the lungs. You should be able to do this. You should know what the impressions of the surfaces are. I will tell you what those are. Identify the lung fissures. Some of you, you must be knowing that the lung has lobes and fissures separating them. Then what is the segmental anatomy? We always talk about, a very important word. Identify and list different radiological imaging. You will have a lecture for this. The black ones here at the bottom, you will have a different lecture for radiological anatomy of the thorax. And you will also, I think, have a lecture for the microscopic structure of the lung. Okay, because we've done that. I know it might not be on, these two lectures are not really on the timetable this time, but don't worry. Something happened. I think we do have these lectures. So Prof. Hemali will be doing the histology lecture. Dr. Udarilinige will be doing the radiological imaging. Okay, so that is your objective. Once this, I'm going to put this up on the LMS. Please keep this in front of you and make sure you learn all of this. Right. Now you have had this lecture on Friday, I think, about body cavities. So this is what it is, the posterior cavities and the anterior cavities. And today we are talking about one of the anterior cavities, which is the thoracic cavity up here, right? See, it occupies only a very tiny space. Abdomen and pelvis are basically encroached into the thoracic cavity also. Right, surface anatomy. You would have heard of topography in your school days when we did geography. Topography is how a surface appears. So this is, we call surface anatomy also that. Now, there are very important lines in your body that you should never ever forget. The first line we talk about is this mid-sternal line, right? The midline of your body's mid-sternal line, or you can even call it the midline. The two lines on either side of the midline are these left mid-clavicular line and the right mid-clavicular line. If you draw a line from the suprasternal notch, the tip of the acromion, and you take the midpoint, that is where you get your mid-clavicular line. It is not essentially the midpoint of the clavicle, right? It's the midpoint of the suprasternal notch and the tip of the acromion, the shoulder tip, right? That area, this part is called, generally, if there's nothing else wrong with that person's body, the mid-clavicular line runs just medial to the nipple on both sides, like in this picture. But you might already know, because you've done breast in the first term, the position of the nipple can vary very greatly, so you cannot go by that. However, the position of these 2 points do not vary. So that is how you find your mid-clavicular line. This is important in doing cardiac examination as well as lung examination also. So you have two mid-clavicular lines. Moving on from this, with the arm raised above the head, you are able to see three axillary lines. So one is the anterior axillary, posterior axillary, and then you get the all important mid axillary line. Never forget these lines either. The anterior axillary line will correspond to the anterior axillary fold, which is demarcated by the lateral margin of the pectoralis major. Right? Remember that? Then the posterior axillary fold is the anterior margin of the latissimus dorsi. So you get this triangle in this region in the middle, which is what we call the safe triangle, all important for procedures involving the thoracic cavity, and I will come to that later. So these are also important lines you will need for your clinicals, you need for your answers in, say, for surface marking the pleura, surface marking the lung, surface marking the oblique and the horizontal fissures. You need these lines. Okay, thorax landmarks in front I have shown in this picture. What do you have? Now we will start from the center. All of you, try and find this jugular or suprasternal notch on your cells. If you come to the sort of the root of your neck or the lowest part of your neck, you'll all feel, you can even see this little hollow in the middle of your necks in the front. Okay, I hope you all have found it. So this jugular suprasternal notch is the anterior margin of the thoracic, superior thoracic aperture, or the thoracic inlet as we used to call it. Okay, from here you understand that this is the superior aspect of the manubrium. This is the manubrium. You can feel it if you go further down, and if you once you drag your fingertip downwards from the jugular notch, all of you should be able to feel a little ridge. A horizontal ridge appears just below the manubrium. This is called the manubriosternal joint or the sternal angle. It's a very palpable landmark. Even in the most obese people, you are definitely able to find the suprasternal notch and the sternal angle. Now, this sternal angle, when you do mediastinum, you will understand. There's a separate lecture for you on that. Is a place where so many things happen inside your thoracic cavity. A lot of significant changes occur at the level of the sternal angle. It's also called the angle of Louis. If you read that, that is the same name, right? Then further down, so an angle of Louis shows the demarcation between the manubrium and the sternum and the siphisternum, which is the other little part of the, the entire sternum in the front, is called the siphisternal joint. It's a bit at the bottom. So if you pass your finger further down, there is a place that you find that there is no bone, and now you're going inwards, right? So that is the lower margin of your inferior thoracic aperture, and it signifies the end of the thorax in the middle, not on the sides, only in the middle, right? So the angle, now then going laterally, moving to the sides from this siphisternal joint hollow area in your bodies, you can feel a hard sort of ridge. That is your the costal margin. So the left costal margin and you have a right costal margin. Angle between these is the subcostal angle. These are words that we are going to be using in clinical examination later on. All right. So I have put the mid-clavicular line for you all to see. So we will be asking you structures that correspond to the place where the mid-clavicular line crosses the left costal margin, or the mid-clavicular line crosses the right costal margin. There's an organ there. So you have to know all these little things. Okay, so same thing on the back. So in the back, what do we get? We get our spine. So there are specific spinous processes that you can feel. Don't try that now because you'll sort of sprain your arms. But if you have little brothers or sisters you can catch, you can definitely go and examine them. You can feel the C7 spinous process very well. It's called vertebral prominence. I'm sure you remember that C7 is a bit of a different vertebra from the rest of it, from the rest of the cervical vertebrae. It has a long spinous process which you can feel in your neck. The next one you are able to feel is the T3 spinous process and the T7. Now, somewhere between or somewhere just with the T3 spinous process, you can feel your scapular spine. In very thin people, you can even see this. Not in thin people, in average build person, you can see the scapular spine. You can even palpate the inferior angle of the scapula. All these things that I have put in this slide can be felt, right? So if you can try and examine if your younger siblings, that's what one of the uses you can make out of it. All right. Again, this shows a corresponding picture, so you get the outer appearance of this man and also superimposed bony structure, so you will understand or you can appreciate which structures that you can feel. Just have a look at this at leisure. Same here. So you now know all these muscles. You have done muscles of the back by now. So go and try and figure out which muscle is where. Okay, so now we come to the thoracic cage proper. The thorax is a very unique shape, right? You have to understand what this shape is because later on in clinical issues, the shape can change. I'll tell you how. The shape is of a truncated cone. All of you know what a cone is, right? When you take a cone and you cut it across the top, so the tip is usually a cone will have a nice tip. If you cut the top off, that is truncation, but this truncation happens in an angle, and this little angle is facing forwards. So imagine a cone which is cut in the top but at an angle so that the angle faces front. See in this picture, in the lateral picture, you can see that the angle faces front. Okay, so there's a narrow opening on top and there's a wider opening at the bottom. So the narrow opening at the top is continuous with the neck. Once you learn neck, you will understand. You'll be able to discuss all the structures that pass from the thorax into the neck. We are not going to do a lot of that now. There's a wider opening at the bottom. Of course, the inferior aperture is closed by the diaphragm, right? And it's exposed. What is below this? It is the abdominal cavity. Now, the other thing you should remember is this diameter. If you look at it from the side, your thoracic cage is flattened antero-posteriorly. Antero-posterior flattening. So it's not really like a barrel. So it's basically, if you took this cone and you squashed it front to back, that is the shape you are going to get. This is very important because you will know later in conditions like chronic obstructive pulmonary disease or COPD, a condition that smokers get. This shape goes away and the patients end up with a barrel shaped or a cylindrical chest. We actually call it a barrel chest. So barrel chest is an abnormal thing. A normal thing is going to be this antero-posteriorly flattened shape. All right. Now, in cross section is also you should identify what the thorax looks in cross section. Again, you should be able to appreciate that it's antero-posteriorly flattened. Okay. Plus, the vertebra is actually a little bit anterior. It has moved a little bit to the front when compared to the back. Can you see? So much so that it gives two little gutters. We don't call them gutters, but of course, when you learn the abdomen, these areas are called paravertebral gutters. In the thorax, we don't call them paravertebral gutters, but you should understand that it's the same shape. So I have put a CT scan to show you the similarities of the two. This is basically how you see a CT scan. So right and left, we look at CT scans from the foot end. I think Dr. Dari might have taught you this. If not, she will tell you. So a CT scan, typically you imagine that the patient is lying on their back and and they have been sliced in half, and you're going to look at the slice from the bottom or from the foot end. Then imagine this part is going to be right, so the right is corresponding to your left and the patient's left is corresponding to your right. I hope you are understanding this. If not, you just go by these pictures, right? It shows you. Okay. there was a bit of an issue in this picture. Let me see if I have named it wrong. Yeah, I think so. So this is wrong, right? This picture needs to be turned around. I apologize for this because we realized it after we had finished posting this on the LMS. So this is the very same thing. So imagine this cross section. I will change it before I post it, right, today. So this should be the opposite side. The aorta should be on the left when you're viewing it. Can you see? This is the aorta on the CT scan. I hope you see my arrow. So this is the aorta. Okay, let me see. Yo, you can't see the mouse pointer. I've been turning it around all this time. Now can you see? Can you see the
Uh,
mouse?
no, madam, we can't see it yet.
You can't
Now we
see.
can see.
Ah, you can. Now?
Now now we can see. Okay,
Now
madam.
you
Now,
can see,
now,
no?
now we can see. Okay.
On this screen, which screen am I sharing? Now can you see?
Yes, madam. Now we can
Ah,
see.
sure. Okay, so okay, now here, now can you see this? The aorta is here. No, I'm telling you that this is wrong. Okay, this is my mistake. Oh, I
Excuse me,
didn't.
madam.
Yeah,
It disappeared again.
it disappeared again. Okay.
When you're moving, it is visible. To
But when I
move,
go to the
it
picture, you
disappears.
can't. No, yeah. Wait,
Yeah.
I'll try and draw. No, this screen. Okay.
Maybe, madam, you can use the mouse pointer in the annotate mode.
Yeah, no, it's because I have two screens here, and okay. See what happens when you're utterly technically challenged. Mordecai, the problem is, wait, I'll try and see. See, I can't take it to my other screen. Can you see the screen? You can't see the two. Oh, sorry. Hmm. No, you can only see this when I'm on my left hand screen. Can you
Yes.
see this screen? What are you seeing on the
Um,
one?
we can see the thoracic cross section screen, madam.
You can see
And
it here.
yeah, yeah. See the
Then
cursor
I'll show it
in
on
that
this.
screen. Yeah,
Cool. This you can see, no?
yeah.
Okay. All right. Then we'll go back to this. Okay. So now what I'm saying is this CT shows a person when you look at them from their foot end. So you can understand that the right is the right and the left is the left is your right, patient's right is your left. This ball-like thing is the aorta. This big structure is the heart. What you see as white is because contrast has been given to this patient, and the entire, wherever there is blood, it has turned white color. So that is what happens with contrast. So this is the aorta. Now the problem with this image is that it's on the other side. So I will have to, imagine this image is flipped. Okay, it's flipped laterally. Then if the aorta comes to this side and this little thing, which is the thoracic duct, comes to that side, then it will correspond to this. So for now, what I'm telling you is this is wrong. All right. Don't think of this. I will change it to the correct one and then upload it. Okay. Okay. Now you can see this also, no? Right.
Yes, madam.
Okay. Now this is what the thoracic cage is. Now we have protective mechanisms in our body to protect the soft structures inside us. So this cage is made up like that. It's a mobile cage. It's not like our skull, which is a fixed cage. This is a bit of a mobile thing. So you get posteriorly the thoracic vertebrae, you get the sternum and the costal cartilages in front, these blue ones, and then you get the ribs and intercostal spaces on the side. So the intercostal spaces are ways that you access into the thoracic cavity. Of course, you cannot pierce the bone. Then there's a diaphragm at the bottom, which is the inferior margin. So this is how the cage is formed. Now, the cage, of course, has three compartments. It has two compartments on the two sides and one in the middle. So the lateral compartments are the pleural cavities, which contain the lungs, The one in between is called the mediastinum, which contains the heart and the great vessels and the esophagus and trachea and all of that. What does the thorax protect? It protects mainly the lungs, the heart, and the great vessels, as well as other structures in the middle of the middle part is called the mediastinum. So it protects the trachea, esophagus, and thymus, which are in the mediastinum, as well as these. Now, these are structures in the abdominal cavity. The liver, spleen, stomach, and the upper parts of the kidneys also project inside the cavity. Can you see? Because the diaphragm is pushed upwards by these structures, the liver is actually inside the costal margin. So if you were looking at your patient and you felt their costal margin, even though you knew that the abdomen is below the costal margin, the liver, which is part of the abdominal cavity, is actually inside the chest. So when people complain of chest pains, what most doctors tend to forget is that lower chest pains can be from either your lung or from a structure in the abdominal cavity. So never forget that. Now I said about these two apertures, right? I will show you them again. So one aperture is at the top. Aperture is an opening, right? We use it generally to talk about cameras. So here one aperture is up here, one aperture is down there. This one is obviously called the superior aperture. You will see it being referred to as the thoracic inlet. I don't like that name. Not only me, a lot of people don't like it being called an inlet, because an inlet implies that things are always going in, right? But if you look very carefully, the veins definitely are going in, but are the arteries going in? The arteries are actually coming out. If you look at the pattern of flow, the arteries are coming out of the thorax and the veins are going in. So if you have some structures going out of it, how are you going to call it an inlet? That thinking is the one which prompted us to change the name to superior thoracic aperture, but you're not going to be penalized for calling it thoracic inlet. Don't worry about that. Of course, esophagus, trachea, and all of those are going in. You will need to identify and name and know the borders of the superior thoracic aperture. So laterally, you get the internal margin of the rib 1, the internal margin of the first T1 thoracic vertebra, the superior border of the manubrium. Those are your margins. The lung apex, the topmost part of the lung actually projects through the superior aperture into the neck. So if people go and fiddle around with needles in the neck, they can actually go and puncture the lung. So it's very careful, very important to know exactly that the lung is projecting at least 2 inches above the level of the first rib and about 1 inch above the level of the clavicle. So these things you will learn when you read up. So here I'm showing the superior aperture again, right? Later on when you do the neck, you will know more about these structures which go in and out, especially the vessels. I'm not going to talk about the vessels. You've seen the brachial plexus already. Excuse me. You know the brachial plexus already. That is also related to the first rib, right? The inferior thoracic aperture. Can you see the borders which I have highlighted in yellow? So the anterior one is actually a bit higher up. The posterior border is lower down. The posterior border is at the inferior margin of the T12 vertebra. The anterior border of this aperture is the xiphoid process. And you get an angulated margin on either side, which follows the costal margin. So read up this. We're running out of time, so I'm going a bit fast here, right? So thoracic apertures, again, so okay, another picture showing the inferior aperture where you will see the diaphragm. Understand how the diaphragm is fixed onto these lower ribs, but it projects upwards and it inserts into this middle white structure called the central tendon. Right? The central tendon is like a tendinous structure, obviously, and that is the insertion. The origins are from the body wall. So basically, the mediastinum is a conduit. It's a sort of a corridor between the neck and the abdominal cavity, and you get so many structures passing. So the esophagus comes in and all the way goes into the abdomen. The heart gives rise to the aorta, which goes a little bit upwards and back down. Then the inferior vena cava enters, piercing the diaphragm. So when we talk of diaphragm, we will need to talk about these piercings. So this is a picture of the diaphragm. You will learn diaphragm again when you are learning abdomen in the next term, so don't worry about it too much for thorax, right? So this is the structure of the diaphragm. This is the esophagus, this is the aorta, and this is the inferior vena cava. All of these things pass through the diaphragm. So now you're going to have a lecture on development, so I'm not going to talk about this now. If you have questions, anywhere the SGA these will be. So there are things called anomalies of the diaphragm, which you will understand once you have learned the anatomy. So the diaphragm originates from several structures, which will be taught to you by Dr. Callum. Right. Let's go to the bony thorax. I told you you had to understand these bones separately. Of course, we can give these for spots. The manubrium, this entire structure is fused together in all the specimens we have. We very rarely have separate ones. And you will see that there's an outer surface and an inner surface. So outer surface gives rise to some muscles, inner surface gives rise to the pleura. So you have to know which is outer. It's generally curved outward. So if you get it to your hands, you will see. Then what is fixed onto the sides of the sternum are the costal cartilages. As people age, these costal cartilages turn into bone. They don't remain cartilage. But in your age, younger or even a bit older adults, this will remain as cartilage. Now, more important in the movement and everything in the thorax, you need to understand this concept. True ribs. True ribs are fixed onto the vertebral body at the back, and it's fixed onto the sternum in front. So there's 1, 2, 3, 4, 5, 6, 7. Even the seventh comes and has a bit of an attachment to the sternum in front. Then you get false ribs. False ribs only fix onto the vertebral body and the transverse process at the back. They don't have attachment directly to the sternum, but they are attached to the sternum via the costal cartilage. So each rib 8, 9, 10, 11, age 8, 9, and 10 are attached to either the 7th or the 6th. Sometimes there's a fusion here, you don't see it as separate. So you can even say it's attached to the 6th or attached to the 7th. You get 2 ribs here. Out of the false ribs, the 11th and the 12th rib don't attach to the front at all. They are only attached to the vertebral bodies and the transverse processes at the back. So these two are called floating ribs. These ribs are kind of like remnant ribs. They are generally taken off in certain plastic surgical procedures where people want to look as if they have nice thin waistlines. These are known to be taken off. So it's a funny sort of rib to have. Doesn't take part in a lot of respiratory movements. Sternum, you should know all the. I'm not going to go through all these different things in the sternum. Check out your bone atlases for that. Then you should know about the ribs. There's a typical rib and there are atypical ribs. The first rib and the 12th rib are definitely atypical. The 11th is also atypical. Generally, we take the 5th rib as a typical rib. So it has a head, a neck, an articular facet. There's an angle to the rib, and you can't see the costal cartilage in the ribs, of course, that you get from cadavers. It's always the way. But in the rib, you will see something called a costal groove at the bottom, each rib. So make sure when you get hold of a rib, do check for the costal groove. Thoracic vertebrae, you must have done this in the first term. Know how to identify and differentiate it. The main differentiating factor is the downward facing spinous process and the costal facets for the ribs, right? So this is how all 3 structures articulate together. When you know the articulation in this manner, you will understand all the movements of the thorax. I will show you that in a little while. Go and read this thing, okay? Because I have to keep to time, I just noticed. Joints of the thorax. This is a very famous MCQ question. Please note down this picture most importantly. These angles, these joints we will ask what type. You have done joint types, I think. You have learnt about cartilage so far. So you understand which are primary cartilaginous, which are the secondary. Generally, midline joints are secondary cartilaginous, right? They fuse. Know which these are. This is a MCQ question. Movements of the thorax. You will have a separate lecture on movements of the thorax. There are two main movements. One is called this pump handle movement. You identify this structure, it's a pump, and the pump handle goes up and down. So that is how your sternum is moved up and down by the ribs on the two sides. So this movement occurs in the upper ribs or the true ribs. This is opposed to the action called the bucket handle movement, which happens in the lower ribs or the false ribs. Here, elevation of the lateral shaft of the rib, it increases the transverse diameter of the thorax. The pump handle movement increases or decreases the antero-posterior diameter of the thorax, and the diaphragm going up and down increases and decreases the supero-inferior. So there are three main diameters in your thoracic cage, and the diameters are differentiated by these type of movements. It is important when you especially go to physiology and learn about the mechanics of breathing. So muscles of the thorax, there's going to be a video, so don't worry. It's a very good video. Hope you can follow this. There are three layers of muscles that you can identify mainly in the intercostal space. External intercostal, internal intercostal, and innermost intercostal. Pay good attention to the direction of the fiber. External intercostal, we say, is like putting your hands in the direction that you put your hands into front pockets of your trousers or your pants. Okay, the internal intercostal muscle is the direction where you put your hands into back pockets, not the vertical pocket. I suppose if you have angulated pocket, that is the angle. And the innermost intercostal, even though it shows that this is vertically downwards, some books actually show that it is the same fiber direction as the internal intercostal. The fiber direction is important to understand. Again, mechanics of respiration, where the external intercostal is involved in one form of breathing and the internal in the other. Okay, so that you will encounter. Muscles of the thorax, again, here I have taken, can you see this little part pulled out of the, so you have the rib, upper rib, lower rib, and this is the intercostal space and the three muscle layers. You find your neurovascular bundle in between the internal intercostal and the innermost intercostal. That is called your plane of neurovascular tissue. Again, have a look at this later on. It's a bit tiny. Once you download it, have a look. It shows the muscles of the thorax in inspiration and in expiration. So you get muscles in quiet breathing and muscles which are involved in active breathing. We will be learning these throughout, like when you go to third year, next year, clinical year, I will come and teach you this again properly. Right. Now, this is another important thing when talking about layers of the thoracic wall. We typically take an intercostal space to talk about layers because that is how you can go through into the thorax. So from out to in, you have the skin, you get the superficial fascia, you get the external intercostal, internal intercostal, innermost intercostal, and then you get this thing called the endothoracic fascia. So inside the innermost intercostal, you get the endothoracic fascia, you get the parietal pleura, visceral pleura. There are two layers of pleura, I'll teach you that, and then finally the lung. So if you pierce the thoracic wall from out to in, we will ask you what are the layers you're going to pass through. Okay, so know this very well. Then we come to the intercostal space. An intercostal space is the space between two ribs, but always remember it has six borders or margins. So one is the superior upper rib, one is the lower rib, one is the internal margin, which is the innermost intercostal, one is the external, which is the external intercostal muscle. Then you get the anterior margin, which is the sternal margin, and the posterior, which is the vertebral margin. So remember this as an elongated box. It has six sides, and you have to remember what these six sides are. Most importantly, what does the intercostal space carry? Remember I taught you about this subcostal groove. The subcostal groove is there to transmit the neurovascular bundle. So you get the vein, artery, and the intercostal nerve going in that groove. Of course, you get another accessory bundle or a collateral bundle which grows in the upper part. There is no proper groove there. Sorry. There's no proper groove there, but you get the collateral branch. They're very tiny vessels. However, the proper intercostal bundle is a very important bundle. We don't want to damage that when we are doing pleural procedures. So when you access the thoracic cavity, you have to make sure that you go from the top margin of the lower rib. Sorry, I'm getting a cough. So when you find your intercostal space between two ribs, you can feel a top rib and a bottom rib, right? So you find the bottom rib and then you go and you find the top margin of that. And if you enter there, then it's safe. You may damage the collateral branch, but that is again very tiny, very high chance that you're not going to damage it. But definitely, if you go from the bottom margin of the upper rib, you can damage the main neurovascular bundle. So these are common questions that you will be asked. If you can see in this picture, you can see some of these vessels and nerves coming out posteriorly, anteriorly, in the side. There are 3 points where the neurovascular bundle pierces the chest wall and comes onto the skin. Know where these places are because these are important points where lung cancer, pleural cancer can track outside, infection can track on these. Tracking means infection can travel through these. I mean, you need to have some sort of pathway of least resistance, right, for something to track, like if there's pus or pus tracking from an abscess or something like that. So these are the points where tumors and pus from abscesses can come to the body wall. So know these 3 places, right? That's this and that. So little clinical thing. We will do some clinical studies later on in this module. There is a clinical lecture which I can actually share with you all. I'm not doing that clinical lecture anymore because we have changed it a little bit to do some ideas. However, the clinical lecture I can share with you. It's on the LMS. Here you can see a tube, a chest tube, which drains fluid from the pleural cavity being passed in. Can you see upper rib, lower rib, and this is passed along the superior border of the lower rib so that we don't damage the neurovascular bundle. Here, this is the neurovascular bundle. This shows what we know as the safe triangle. The safe triangle is the triangle formed by the base of the axilla, anterior axillary line, mid axillary line, and fifth intercostal space. Google says that the safe triangle is from the lateral edge of the latissimus dorsi muscle, which is the posterior axillary line. That is wrong. If you go beyond the mid axillary line, if you try and cut and put tubes there, you can damage the long thoracic nerve. Remember the long thoracic nerve? Remember what that is and remember what muscle it supplies. So you don't want to damage the long thoracic nerve. So the actual safe triangle is this triangle. Sorry, this keeps popping up. Have a look at this and remember the proper safe triangle. Oh, sorry, what happened?